We now continue with lecture 22, the digestive system 2, duodenum, liver, pancreas, and spleen. And we pick up with the development of the pancreas, and we'll finish with the spleen and anomalies of development. So the pancreas then forms from the dorsal and the ventral pancreatic buds of the caudal foregut. It lies along the dorsal abdominal wall inferior to the stomach. The parenchyma and the islets are derived from the endoderm, so then we know the stroma is going to be developed from the mesenchyme in this area, and insulin secretion will begin at week 10. So here we are looking at figure 1210 from our textbook, and we notice the ventral mesentery on the anterior surface of the stomach, or ventral surface, and the dorsal mesentery on the dorsal surface. We see at the junction of the stomach and the duodenum the posterior diverticulum, which is the dorsal pancreatic duct, and on the anterior surface, again, the liver diverticulum that has now become the liver bud, the gallbladder, of course, the common bile duct would be here, cystic duct would be forming there, and the ventral pancreatic bud. And then the duodenum, the remainder of the duodenum from the midgut will be down here. So there is a dorsal mesoduodenum that extends for a longer distance than the ventral mesoduodenum. This portion of the ventral mesoduodenum here is going to become the hepatoduodenal ligament. So we are, in this slide, seeing the rotation around the stomach and the duodenum, and what we are envisioning is the ventral liver bud, collective structures from that, is going to migrate posteriorly and meet with the dorsal pancreatic bud, as we see here. And indeed, we see the level of section F to be forthcoming. This has rotated around. They have met and fused, and we have the more adult structure here with the common bile duct still ascending up through the free edge of the lesser omentum, the hepatoduodenal ligament. Now let's take a look at the panel D, and we see it even slightly farther advanced. We see the spleen developing within the mesenchyme of the dorsal mesogastrium. We see the greater curvature of the stomach and the pancreas lying posterior and inferior to that, and the common bile duct extending on up to where it meets the cystic duct, the common hepatic duct, and the right and the left bile ducts. So we'll be looking at these planes of section through here to follow the development of the internal aspect of the duodenum with reference to this opening into it from the pancreatic duct and the common bile duct. So we see the head of the pancreas here, the tail of the pancreas over in the posterior left portion. And now we see in this panel, in this figure, panels E, F, and G. They're rather small, but that's fine. What we are following is the ventral pancreatic duct and the bile duct coming around. First being on the ventral surface of the duodenum, it is going to rotate around and meet with the dorsal pancreatic duct within the dorsal mesentery here, and then this, of course, is the duodenum. So panel F is showing that migration around, and panel G is showing the final arrangement where the ventral pancreatic duct, not the ventral pancreatic duct, but the liver bud from which the ventral pancreatic duct originated becomes the final major opening into the duodenum, the opening of the bile, and the main pancreatic duct. The dorsal pancreatic bud, the patent pathway, remains as the accessory pancreatic duct. So most of the pancreas drains through the original ventral pancreatic bud duct into the common bile duct, and then through that into the main pancreatic opening into the duodenum. And we see the ventral pancreatic bud becomes the head of the pancreas, and the body and the tail is formed by the dorsal pancreatic bud. So this slide is showing us the section through the embryo pre-fetus just above the umbilicus at 3 stages. We would call this one where this is the adrenal gland forming. This is the stomach with the hepatoduodenal ligament here containing the portal vein and the biliary duct and things that we talked about before. This is the pylorus, and this is the duodenum here. So that's the hepatoduodenal ligament in this area. In this view, we see the adrenal glands are becoming relatively smaller, and the duodenum is here, and we see the portal vein going into the liver. And then here we can see the pancreas developing in the posterior abdominal wall with reference to the duodenum. So the pancreas is present at this level. So which parts of the pancreas develop from the ventral and from the dorsal pancreatic bud? How is the duct system formed? So the ventral becomes the unguent, or the hook part that hooks around the superior mesenteric artery, and the inferior part of the head of the pancreas. The dorsal is the remaining parts of the body and the tail. The main pancreatic duct is formed by the distal part of the dorsal pancreatic bud and the entire ventral pancreatic bud. So the accessory duct develops from the proximal part of the dorsal pancreatic bud, as we had mentioned before, proximal with reference to the duodenum. So next we can describe the development of the spleen. It is a lymphatic organ that is derived from the dorsal mesentery, not foregut, so it's the mesenchyme within the dorsal mesentery that is going to differentiate in this selective clustered area. The hematopoietic nature of this organ is emphasized here. It is one of the major hematopoietic centers late in fetal development. So we've already talked about liver being one of the earliest. Now the spleen will contribute at a later point in the fetal development, and it retains that potential even into adulthood. This slide is showing us a very interesting website. You see the link down below here. I've checked this just recently, and it still is operational. You should go and visit this site for a variety of the system developments that we will be looking at. I believe this one is the digestive system here. So I'll let you go and visit that site to see it. It's very nice three-dimensionally with scanning electron micrographs that are colorized to follow the actual events that are occurring. So now we can talk about defects that occur in the development of this area. And first we'll talk about the esophagus. We had mentioned that it starts first as a tube, but then the lumen becomes obliterated by a solid core of cells as there's a rapid growth in the epithelial cells, and the failure of that to reopen is called atresia. So there's a complete blockage associated with the tracheoesophageal fistula that we had mentioned with the respiratory system, and this is usually in premature infants, frequency of 1 to 3,000. Stenosis is next, where it is just a narrowing, so there's still complications, but it's not quite as bad and completely debilitating as atresia. Still, stenosis needs to be repaired as well. So it's narrowing due to an incomplete opening in week 8, So there can also be a shortening that will cause a congenital hiatal hernia where the stomach will be pushed up into the thorax. So there can be stomach defects such as pyloric stenosis. They're the same mechanisms. Duodenum can have stenosis or atresia. The stenosis is the full occlusion. Atresia is a narrowing. And then the liver and the gallbladder, there can be biliary atresia, so problems with the flow of juices, if you will, through these areas. So this is figure 1211 from the textbook, and it is going to show how some of these aberrations can occur. So we see in panel A the classic ventral pancreatic bud and dorsal pancreatic bud, and we know that the original liver bud extension, now the bile duct, is going to migrate around posteriorly and meet with that. Well, if there's an aberration to that where they rotate in the opposite direction and meet, then there can be an annular process rather than just the hook, the uncus that was mentioned. There can be a complete annular surrounding of the duodenum by the pancreas, and this can create an obstruction. So this might be a contributing factor to causing what we see here, a narrowing of the lumen called duodenal stenosis. You notice that proximal, or closer to the mouth of the stenosis, there's a dilation of the duodenum. So it still will be distinct from the dilated stomach that has developed. The duodenal atresia would be where there is no lumen, and the proximal dilated portion might even be a bit more extensive, and then there would be a decrease in size of the distal duodenum that is distal to the atresia. So these panels C, C1, D, with D1, 2, and 3, and E and F similarly, show the three possible outcomes. One is the normal, where the epithelial growth has filled it, what we first see here in C, the epithelial plug, and then there are vacuoles that will begin to open up, and ultimately they will become continuous and basically erode away into a normal lumen. If this erosion, if you will allow me to use that term, is incomplete, then there will be a narrowing, or not the atresia, but the stenosis as we see here. So this would result in this type of a situation, having the duodenal stenosis. Obviously, if there's a lack, even if it's just in a small restricted area, of the breakdown so that there's an opening, then the duodenal atresia, as shown here, would occur. So this is a case study, obviously dealing with one of these situations. The physician's names are listed here. The chief complaint was a one-day-old full-term female had bilious aspirates. So for some reason, the bile from the liver secretions were exiting through the oral cavity. So this is obviously the wrong direction, and something is preventing it from going in the appropriate direction. So the clinical history, the patient was a full-term female, 1 day old, noted to have copious secretions in the delivery room where 50 cc's of bile-stained gastric secretions were aspirated. So they always stick that little tube down the mouth to open the larynx, to clear it of any type of liquid to make it easier for breathing. So upon further questioning, it was learned that a prenatal ultrasound at 20 weeks had revealed fetal bowel distension with no evidence of polyhydramnios. So there's no excess amniotic fluid to explain this dilation of the bowel or distension of the bowel. So the clinical physical exam, the abdomen was soft with a palpable mass. So this distended bowel was palpable, and of course it was soft. The clinical labs, there was no contribution to the differential diagnosis based upon that. So the Initial clinical differential diagnosis was duodenal atresia. So the imaging findings, we'll see those in image 1 in just a moment. There's an abdominal film from the first day of life, showed a double bubble sign. The supine abdominal film from the first day of life shows the stomach and duodenum to be abnormally distended with air, with a small amount of gas distal to the duodenum. So this is shown here. So here's the large dilation of the stomach, and then a large dilation of the duodenum. So these typically would not be this large. We can see the pelvis here inferiorly, and the 11th and 12th ribs here, with the stomach in this area, and there, of course, is the heart within the chest wall. So the imaging differential diagnosis was either duodenal atresia or duodenal stenosis. So upon surgery, the operative findings were such. The patient was explored in the first day of life via a right supraumbilical transverse incision. The duodenum was seen to taper between the second and third portions. A nasogastric tube could not be advanced past this area of tapering, so this means atresia, more likely atresia. There appeared to be a membrane obstructing the duodenum at this point, again supporting atresia. A duodenotomy was performed, which confirmed the presence of a thick membrane completely obstructing the duodenum, verifying duodenal atresia. Bile was seen above and below this membrane. The bile was coming from one papilla above the membrane and one below it. The dividing membrane was then incised. Simply cut it, make it patent, and then, since this is the first day as a neonate, very rapidly things will normalize. So here we see figure 1, an operative photograph shows the superior retractor up here distracting the proximal duodenum, this little tube here, and the inferior retractor distracting the distal duodenum. The membrane is seen between the retractors. So this membrane here is completely sealing off these two levels of the duodenum. So this shows the forceps pointing into the membrane there. So the pathological findings were none. The final diagnosis was duodenal atresia with air passing distally through the pancreatic ducts. So we had our two pancreatic ducts that were, one was above and one was below the point of atresia. The follow-up and prognosis, the patient had an uncomplicated postoperative course, and this is the source of this case study. So that completes our lecture for the development of the pancreas and the spleen and the disorders, completing lecture 22.